occlusion, which we are going to be trying antegrade route. And of course, Dr. Sharma is going to review many cases and review of the trials discussed at the TCT. So without any further delay, let me take you to the Cardiac Cath lab where Dr. Sharma and Dr. Kinney are scrubbed. And we also have a guest in Dr. Roxana Mehran, who doesn't really need any introduction. Samin, good morning. Challenging for your logistics.
In the history of CCC Live, this was the first time where there was equipment issue. We have had a delay. I remember that about 45-minute delay a few years ago because of the snow blizzard. And maybe 10-15-minute delay was iatrogenic by Dr. Sharma. But otherwise, we have no interruption. And this is the first time we have about an hour delay because of our equipment issue. And hopefully, the organizers conducting this meeting, this our webcast will learn it so it doesn't happen again. So clearly, as you mentioned, that we'll talk about various trials and Roxana Mehran with the twilight. That's what we made the announcement this morning, is here to give expert comment. Retrograde. Can we start the slides? These are usual supporter, disclosure, no change. This is the case number 124, 50-year-old female, has multiple CAD risk factors as shown there, and has a new onset angina for is also diagnostic or guide? Diagnostic. Yeah, both diagnostic catheter. You start seeing a very faint micro channel. So whether you call it a total occlusion or you call it subtotal, no? 10 millimeter.
On medication, and she's young. I mean, for sure, this is a revascularization appropriate for revascularization.
So with that note, we are ready. So we have a JL4, diagnose 5 French on the left side. Although we have chance to upgrade in case we're thinking about retrograde. We got good collateral from the septal to the PDA, but antegrade now we see, and this is the guide catheter now. So this is with the side holes. Yeah. Okay,
Okay.
good. Now, what you
Let's
don't,
do a,
yeah,
let me
you
see
have
with
to
the
have
light.
fielder wire and
We'll get
you
a
want to go
fine
fielder
cross.
XT?
Fielder. Ready?
You get fielder XT. Yeah,
No, no.
Samin, in the
yeah,
previous
good. Yes,
CTOs, we always used to teach them
Go.
FMC, Fielder Miracle Confianza.
that's it.
And I'm
That is it.
sure that's modified by Gaia and some other wires.
Yeah. So if it become now FGC, fielder Gaia and Confianza.
Fantastic. So, Samin, for our audience, what's the difference between a regular fielder and the XT? Roxana, welcome to the webcast today. Pleasure having you. First of all, congratulations on Twilight. You were the queen of the show at TCT. I mean, it was unbelievable. The attention the trial got and its significance, I think easily the most relevant topic today, and we hope to benefit from your experience this morning.
But, but from the original, trial point of view and so, but everything otherwise was just extension of
Inject now.
the regular, trials which we have been presented before. The lot of structural follow-up trials and so, but it's really the randomized point of view was the only one trial presented.
Well, I appreciate that. I mean, obviously, I'm biased to think that yes, that was the great
Yeah.
trial, and I think it's not about one person. It's about a huge team effort and a very dedicated steering executive and committee that we had, as well as my partner and Dr. Usman Baber, who was the chair of the Clinical Coordinating Center. So we really had a fantastic team. Hundreds of people worked on this trial for it to work as it did, to deliver a high quality trial to the world. So we were very proud of that. And Dr. Sharma, your efforts and your support, both at Mount Sinai, but on a general sense, and how you came up, your idea about dropping aspirin and testing that, we should not forget. So I think everything works in that way. So
And Usman was here in the lab last month.
yeah, that's
Last
good.
month episode. So see, there is a lot of calcium there. You want to think about the Gaia now?
Get us the Gaia.
Gaia 2.
Three.
On to the next wire here.
Yeah. So it started with a fielder. So let's make a little curve on the Gaia. So that's
okay,
exactly stops at that level where it is the total occlusion, the short segment.
I got to go
So,
back to this.
so I think what's interesting about this patient and whether or not a patient like this would fit into Twilight is something that would be decided after the procedure if the interventionalists or the clinicians want to send this patient home on ticagrelor, because this is a stable presentation. It wasn't an unstable syndrome. So the indication for the use of ticagrelor and this patient fitting, angiographically she fits, and she has the clinical criteria as a woman.
Yep.
But I think
diabetic, yeah.
whether or not you're going to put this patient on ticagrelor is the question at the end of the procedure on how you make that important judgment. And if that's the case, then going to a a single antiplatelet therapy with ticagrelor alone after a period of both treatments might be something to be considered based on the Twilight study. And we'll discuss that hopefully soon.
Absolutely. One of the questions I can ask you upfront, Roxana, is every observation you've learned from Twilight, can those be extended also to prasugrel?
I don't think you can do that and say that until, like, if you remember, the Plato study showed an important interaction between the aspirin dosing and ticagrelor. We didn't see that with prasugrel. If there is to be doing this kind of an important, you would imagine that it should work, but I would be, in my mind, I would be more, would be more cautious than optimistic. We'd have to make sure that that's the case.
Excellent observation and so relevant. Anu, it wasn't in the true lumen there?
Or no, in the branch.
Yeah,
Probably in the small acute marginal or RV
One
branch.
of the
But
several
it's starting to
branches.
look exciting that she's going to get in there.
You want to go to RF view again?
Let's see. No, same thing, right?
Mm.
Yeah. RAO. Only question, see the Gaia curve is a very soft curve.
Yeah.
More,
Samin, a lot of controversy got generated about the Excel trial.
Yeah, so actually you'll see, purposefully I omitted that trial from my today's discussion, which will show the point, and I try to invite both Greg Stone and Dr. Puskas in our next month's webcast and really discuss, because I think that's something which we all need to discuss, had to be in the open form, and I know there has been a lot of backlash for the interventionalists that the trial was adulterated and
No, so I think it should be, because I was on the executive committee, let's make sure to set the record straight about the negative comments that are all hearsay and unfounded and untrue and frankly quite damaging to our integrity, which needs to go away. So I'm really glad you're bringing two of the PIs to discuss that, but I think also it's important to note that there was never such a thing about a change in the endpoint. And certainly the adjudication was blinded and well conducted, and the data are the data. And there is clearly a difference between the timing and the mortality curve separating, which was presented beautifully at the both in the New England Journal article as well as in the presentation. So I think it's great that you're doing that to bring Dr. Stone and Dr. Pluskas here.
Yeah, it's an important enough topic.
You want to bring
so
your
that
thing a
let's
little bit
put
further
the
because you're in the right
controversy to
lumen.
rest.
I think, no?
it's not going further down.
Oh, okay.
Guide is coming out.
Yep.
Yeah, the guide I noticed was being
So
pushed
now
out.
other question is, we can get a little more aggressive guide also. With the AL 0.75 or so, you need to make an additional curve.
But she's made a lot of progress. I mean, she's almost there. If anything, I think she's past the CTO.
It's
Yeah.
just there, it's been fine. Okay.
In a
So
small
that's why I was
there,
wondering, would you bring your microcatheter closer?
This is why we can throw. So this is what now, tell them what,
This is Confianza 9.
it's a Confianza 9 now.
Also, it's important to note that Dr. Kinney checked
we'll
the
do
LVEDP
later today, let him know
before the procedure, and she found an LVEDP of about 8 to 10. So she's hydrating the patient, watching the amount of contrast that's being given. These are all the kinds of things that she's doing to make sure that the procedure is safe and that there are no untoward effects with contrast and hydration and all of that for acute kidney injury. And so that's another important point for CTO procedures.
So you can see a lot of calcium. It's like does not
Yeah,
go
so there
smoothly.
is some calcium there.
Yeah, actually there were a lot of calcium
Because you
proximally.
showed that you were going to do rota maybe.
Yeah. So that's what we, calcium, but today it looked like
Here
that
she
at the
goes.
level of the lesion was less, but proximally definitely was quite a bit of our tram track in the proximal part of the RCA.
Yeah.
Get That is a AL.75 ready.
Yeah, it's pushing the guide back a little
Yeah.
bit. You're right. Okay.
In many of these complex cases, you go with the Godzilla or guide liner with your over-the-wire system, and so provide this full support. This guide issues becomes less important.
No, that is if you have a proximal vessel, not in this case.
Yeah. You want to see a little die? You want to go to RA or which? Good.
I
I
think
mean,
maybe
the first question was exactly about use of guideliner here.
Yeah. So actually, you know, the strategy could be nowadays what we learned, that your 6 French guide catheter, you have little room proximally. So you go with your fine cross or teleport or any other catheter, and then with your wire, along with the Godzilla or guide liner built in. So what we do, this guide support, guide coming out will be minimized.
I think you're going to have
You
to
want your
change
miracle
guide.
group?
Anu, a little departure from seeing you do at least a dozen of these similar CTOs of the right, and even I'm a little surprised that you had not started with an amplats.
Yeah, definitely implant will give a little better support.
We can change it.
And do you want a guideliner at the same time? No. No, here you can also use a center if you want a center cross. With a
No,
7.
cannot. You need a proximal vessel for the center cross.
Yeah, a little bit.
No.
But that requires also 7 French. So now which direction this is going? You want to take a little picture?
I think Gaia has gone subintimal and created a lot of subintimal tract there.
You want to see retrograde or
Yeah.
no?
You cannot see.
You know, retrograde, it's going
Okay,
more.
go with the, get the, yeah. No, AL.75.
Okay. So while they're changing the guide,
Yeah,
and I
I
know
think it's
that
a good idea.
Roxana, Dr. Mehran has the commitment. We just go through our trials. Go back to the slides, please. And
This
so
side
get the
also?
input. So by the time we'll have 2 points I will be discussing. And of course, we need Roxana, and she has commitment in next 15 minutes. So twilight trial of aspirin discontinuation and the depth trials from the TCT 2019. So all the various trials, I just picked up the 3 depth trials which were presented. So clearly with the twilight, as you know, the whole issue about efficacy and long or short duration with the bleeding, all have been the P2Y12 inhibitors, abbreviation 3 to 30 months. And the background basically has been that every time, which we have put in the blue, that very short mandatory DAP duration after DES might be an attractive option to decrease bleeding with a better stenting. Now, if not associated with increase in ischemic events, disproportionate to the reduction in bleeding event. Now, numerous trials have evaluated short and prolonged DAP, focusing on P2Y12 inhibitor, but aspirin was continued in all the trials in the past. What about aspirin as a culprit for bleeding and no effect on ischemia after PCI? That has been the theme in last 1 year, that take away the aspirin with the global leader trial where the aspirin was given for 1 month compared to ticagrelor, continue for another 24 months and then of course aspirin was continued all throughout in the reference treatment, whether ticagrelor or clopidogrel in stable CAD. And we learned the endpoint of the death and MI showed trend towards lower in terms of the efficacy point of view or primary safety point of view, death and MI 3.8 in the experimental treatment where aspirin given for 1 month, and compared to when it was continued, it was 4.4. And then look at the bleeding, there was no difference in bleeding. So question basically was that aspirin discontinuation, stent thrombosis was identical, no difference. So then we have the Augustus trial, although it's not true directly with, but they have about 1/3 of the patient had ACS PCI. And if you see here, with the apixaban plus placebo, not the aspirin, had the best outcome. Lowest bleeding, and on the right side, lowest event rate. So seems to be that you have even with the NOAC, single antiplatelet therapy, because no need for giving the aspirin, did better. You know, this was the 2 by 2 factorial design, but the ACS PCI group, the same data they have others. Then we have two trials focused on continuation of aspirin for 3 months or 1 month, smart choice and stop DAP2
right?
from Japan, and basically showed both similar outcome. That is identical death, MI, stroke, and stent thrombosis, no signal at all. No signal at all. Rather, maybe things are a little in a different direction, particularly with the dual antiplatelet therapy, which is the bleeding. So seems to be the stage is set that to take away the aspirin, again, these both trials stop the aspirin, continue P2Y12, and 2/3 basically was the clopidogrel, 1/3 was the ticagrelor or prasugrel in the smart choice trial, and showed that benefit. So that led to this trial of ticagrelor, which is highly publicized and presented by Roxana Maran, and I'll ask her now to talk about this, take it from here, that what basically we learned from the trial and how impact it will have in our the future recommendations. Roxana.
So thank you, Dr. Sharma, and for including the Twilight study. But important, I think, just to put this into the context of what's been out there, the only blinded withdrawal of aspirin in high-risk patients was actually with the apixaban trial in Augustus. Every other trial that you just saw presented was an open-label trial and truly underpowered for the ischemic endpoints. So what we hypothesized is that in patients undergoing PCI who have a high risk for both ischemic and bleeding complications, but have completed a 3-month course of dual therapy with ticagrelor plus aspirin, that if we continue with ticagrelor monotherapy, we would have superiority in terms of clinically relevant bleeding, and we would not lead to important ischemic harm. So our objectives were twofold. The primary one, showing that ticagrelor monotherapy would be superior and would have an important impact of the 12 months, over 12 months in reducing clinical relevant bleeding. And then importantly, the key secondary objective was to determine the impact of such a strategy on major ischemic events, including all-cause mortality, non-fatal MI or stroke, amongst high-risk patients who had undergone PCI. And importantly, what you needed to do in the clinical criteria is that the patient needed to be, this was a prospective, placebo-controlled, blinded, double-blind placebo-controlled trial in 187 sites in 11 countries. All you needed to do is to meet the criteria that are listed here. But what you needed to do is that the clinician, first and foremost, needed to decide that the patient needs to go home on aspirin and ticagrelor for whatever reason that they felt it was important. But we also wanted to make sure that there were important clinical and angiographic criteria that would put this patient at risk for ischemic or bleeding complications, and they're all listed here. And you can see for this particular patient here today, we meet the criteria of a female gender and an important
diabetes and long run,
as well as a very long stent, as we will see, hopefully, and we'll see how it goes. And calcific lesion, there may be a requirement for atherectomy. So you can see important angiographic and clinical criteria listed here. So here's the design of the study. There was an open enrollment period with open, open label fashion where patients were enrolled with open label aspirin and ticagrelor, aspirin at 80 to 100 milligrams a day, and ticagrelor 90 milligrams twice daily. At 3 months, patients were seen and pill counts were done. Evaluation of ischemic and bleeding events were done. And if they were adherent without major ischemic and bleeding complications, they were then ready to be randomized to a ticagrelor plus aspirin versus ticagrelor plus a matching placebo with a 1-month phone call after randomization and a 6 and a 12-month in-person evaluation with pill counts. And then, and after 12 months after randomization, there was an open observational period to look for a rebound phenomenon. So this was a very, very intense study with a lot of in-person evaluation, monitoring, etc. And it was a global study. You can see that we had an incredible global representation across the globe with North America, Europe, and Asia, including China and India. And thanks to Dr. Sharma for his leadership and Dr. Upandra Kaul to be able to get to India. And then, of course, for Professor Han Ya-ling to be in China. And we had these amazing, amazing country leaders that helped us. Here's how it went. 9,006 patients enrolled, 7,119 who were adherent with no ischemic events, eligible for randomization. We had 98.5% evaluation of the primary and key secondary endpoint and 99.7% at 15 months with vital status.
But that's amazing. 99.7. I mean,
that's right. We
unbelievable follow-up.
We worked very, very hard not to miss a single patient for follow-up.
In an 18-month trial to do it.
That's right. And it really has to do with you know, and whenever anyone says clinical trials are failing, we can't do studies, when you have an engaged physician group to answer a really, really important question that's clinically relevant, everyone will work for the trial. And we were really, the funding was very small for this study. This was really a sponsored study from Icahn School of Medicine at Mount Sinai. And I'm really proud of my institution for sponsoring this study, for Dr. Sharma's support to make sure this happened. And we also did an incredible sub-study here at Mount Sinai. But you can see that the blinding and the randomization works beautifully. The clinical criteria and the angiographic criteria and procedural details are exactly matched. These patients had 64% multivessel disease. We had 38% diabetics. We had 65% acute coronary syndrome. The total stent length was over 40 millimeters. These are complex patients with difficult lesions, and we were able to follow these patients. And if you just think about this, if you take a patient like that and you leave them on aspirin and ticagrelor for an entire year, you will have a BARC 235 bleeding of about 7.1%. If you then take away aspirin and just replace that with ticagrelor monotherapy, you will reduce that to 4% with a 45% reduction in bleeding, and the numbers needed to treat, only 33 patients to treat to avoid these important bleeding complications. You can take a look and see that across the board in every bleeding parameter, there was a major reduction in bleeding. And what's now important is to say, well, you reduce bleeding, so what? Of course, you stop aspirin, you don't bleed. But what I said is what's important to note is that can we keep that key secondary endpoint in line? Did we cause harm? And believe me, I was very, very nervous about that. And we absolutely had no difference, 3.9% across the 12 months with a very important P non-inferiority, less than 0.001, very important safety endpoint on a per protocol analysis for these patients. And you can see that we did not in any way cause harm with death, MI, and stroke. And take a look, even stent thrombosis, death, myocardial infarction, exactly the same, were in the right direction. There were a few more strokes in the patients who were on placebo, but really these are rare events, should never be evaluated in any way. Take a look at the pre-specified subgroups, completely in the right direction for reducing bleeding with placebo in every way you could look. And in fact, our ACS patients who went home, which is the first time we're seeing ACS patients with a shortened duration of DAPT going to a monotherapy. And we will be presenting all these data. Dr. Baber will present that at AHA as a late-breaking trial. We're very, very thrilled. And we will also be presenting a pooled analysis of Twilight and a subgroup of the Global Leaders trial for a major analysis of understanding whether or not we can even cause improved and enhanced endpoint on the ischemic endpoint. But take a look, the bleeding is better even in ACS patients. And if you look at the landmark analysis for beyond 12 months, when you're an open label, when you go back to your regular therapy, there was absolutely no rebound. Most of these patients ended up on aspirin, but we will see we will evaluate what they really ended up in. So importantly, whenever you look at these ischemic endpoints, you're always underpowered. We assume we got about a 4% rate. You could always go towards the null, and you have to take it by caution into that. So having this important thrombogenicity sub-study led by our Mount Sinai group here in the cath lab with the incredible research team, and in conjunction with Professor Juan Bataman, using the Bataman chamber, we evaluated of the 128 randomized patients here at Mount Sinai, 51 agreed to be part of the important thrombogenicity sub-study. Our idea was, can you actually see the blood being more thrombogenic if you withdraw aspirin? This is a really, really important evaluation. The patients had their blood perfusion assay done at the time of randomization, and then they came back about 1 to 4 months after they were on the blinded study drug, and they had their evaluation. Here's how it went. The patient's blood went into this chamber, the Bataman chamber, where there is a tunica media that is there, a porcine tunica media that is in the chamber, that's disrupted, that basically forms has a prothrombogenic substrate, which is the tunica media, and causes clot formation and mimics arterial stenosis. This goes in a bath, going through a low to a high shear stress. The blood goes through the chamber, and then we look at that tunica media and see how much clot or thrombus is formed on top of the tunica media. You see that at the bottom, and the thrombus area is quantified with very, very excellent and validated techniques. And what we saw with this ex vivo thrombus area by treatment, we showed absolutely no difference in the blood thrombogenicity with aspirin or without when ticagrelor was on board. So in other words, withdrawing aspirin does nothing to the blood thrombogenicity and the thrombus area by the treatment group, as you could see here. And an important, very important validation of this is that there was more arachidonic acid and collagen-based, using collagen and arachidonic acid in absence of aspirin. So it validates that this study, this platelet reactivity study, is absolutely correct, and that the blood thrombogenicity does not change, and it corroborates very, very nicely with our important evaluation that with patients who undergo PCI, complete 3 months of dual antiplatelet therapy with aspirin and ticagrelor, going to an ticagrelor monotherapy for the next 12 months, you have a lower incidence of clinically relevant bleeding and no higher risk of death, MI, and stroke. And we corroborated that with a thrombogenicity sub-study that actually told the exact same story about the blood thrombogenicity, so corroborating with no risk of death, MI, and stroke.
And that is it. And that's actually go to, let me complete this one. Yes, this was a nice editorial by David Moliterno. No, it was in the Smart Choice and so in the JAMA.
Okay.
It showed actually, they described that the title was, is it time to cut the cord with aspirin? And they actually describe in the last paragraph that not yet till the twilight trial is presented. This was editorial by Moliterno in JAMA. And I would say now, yes, it's the time to cut the cord with aspirin.
Well, I think, well, that's nice, but I think we have to see how that goes. So,
Roxana, before
Dr. Kinney, in the short time, has already crossed the lesion.
All right, come back on the floor now, please.
Of course, she's crossed the lesion.
Tell us what's happening now.
Nothing, we crossed with the Confianza 12.
Which one? Confianza 12. But why balloon is still not crossing?
No. Roxana, before you go, one or two quick observations. Again, Samin has provided the practical take-home message. Is it time to cut the cord? Probably it is on the basis of such strong evidence. My observation is that truly, if you understand the thrombogenicity sub-study, then it is really no surprise that the results of Twilight are what they are.
No, that's true, but I think it's important to note that with all due respect to everyone's enthusiasm about cutting the cord with aspirin, let me bring everybody back to earth that what we evaluated in a blinded placebo-controlled trial are twilight-like patients. We cannot say this is the case for STEMI patients. I'm hoping we're working on a twilight STEMI study right now that we're designing, and hopefully have we'll be able to do that with my twilight investigators. Everybody's excited to do that work, so we're gonna hopefully do that. But we need to think about these important strategies going forward, because what we want is that sweet spot of bleeding avoidance strategy that doesn't cause ischemic harm. Here's one of the strategies, and I'm hoping that we could do more of those in the future.
Absolutely, words of wisdom, Roxana. Thank you so much for coming over, and we stay on
Well,
track
thank you
and
for
get you
having
out
me,
of
but
here
look
by
at this
9:30.
gorgeous. Thank you so much.
Good.
Thank you very, very
All right.
much. And
Good.
thank you, Dr.
Thank you,
Sharma.
Roxana. Good.
And good luck with all your excellent work.
Superb.
So, Samin, a lot of success there in the case.
So
A
it's
lot
still
of
a
viewers
little
have
struggle,
asked some
but
questions.
that area of the CTO is still giving little trouble. So now what Anu is doing is dilating the proximal area so that can get the guideline a little further, right? That's the plan?
Yeah.
And I
Guideline
think
What
for
balloon is this
whatever
now?
it is worth,
Even
the
one balloon
AMPLAT's
didn't go further,
contributed.
right? Even one balloon didn't cross. Oh, 125. We didn't use 1 yet. Okay.
Okay, go up.
The sapphire was not used. Okay.
No, we probably will be good down. So this is a case where you cannot.
Tell them
guideline
what's
or not.
happening in room 6. I need to know.
Okay, get the sapphire now. If not, then you have to think of laser or no.
The
Anu,
question,
what
if we
are
cannot do anything, then we have to think about the laser. Yeah.
a summary of what you all did here?
So
We
this is a
changed the
Confianza
guide.
12,
Yeah, we changed the guide and we went with the
Godzilla,
Godzilla.
and 1.5 balloon did not go 1.25. We are trying to go with
Then
the.
of course I recross because I have a feeling the Gaia 3. I know everybody gets excited about Gaia, but I have a feeling Gaia takes a lot
Subintimal.
of subintimal. Yeah. So then right from the proximal RCA entered with the Confianza 12. Yeah.
Now, other question is that can we go with the Corsair? Corsair will with a tapered tip, pointed, will have a better chance.
The new Corsair?
What happened?
No, they have a newer Corsair. Okay, we can try that. Let's try with 1.0 balloon.
Yeah, 1.0 balloon
Otherwise-
first. Yeah.
Now this is
Give us
also
1.0
not
balloon.
going. You see this?
Yeah.
Because I think we are hitting that part of the
Yeah.
vessel.
Good.
So try 1.0, otherwise Corsair, otherwise laser.
So, Samin, Twilight is really the big enchilada, no? I mean,
Yes.
compared to
That's
that,
it.
Onyx is nothing. And
Yeah. Anything else is nothing.
right.
No, this is particularly, but again, I just want to say this concept is back in 2012 and 13, where I would say Twilight was formulated, because I was had a very low threshold of stopping aspirin, particularly when patients were getting ticagrelor. And ticagrelor we are using in unstable, stable patients also, although having a trouble with insurances, but let's give it for 1 month. And so aspirin, I was stopping in those tough cases within a one month even. And that was basically, but when Roxana went to the AstraZeneca in Paris for the trial, they did not agree for 1 month interruption. They agreed for only 3 months. That time global leaders was not, nobody knew about the protocol. We are talking about 2012-13. But I think.
Are you suggesting to interrupt it at 1 month?
1 month. Oh yeah, there's no question in my mind. I think you can safely stop at 1 month. And I think more and more, and we learn on the the smart choice, and so that 1 month is okay. But whether it's a 1 to 3 months is an issue, and I don't know whether guideline will change, because global leaders will not change the guideline. Twilight will, because global leaders was not positive trial. By definition, it was a little trend, while Twilight was, positive all the way. No ischemic signal, and definitely the bleeding was kind of bye-bye.
So it should be almost given here that Prasugrel will try to demonstrate something similar too, no?
Well, the only problem with the Prasugrel now, it became generic. Once it is generic, unless some institute like in Germany and so, they do those the state run, national run trials will be a trouble.
Okay, down.
But there's no question in my mind, 1 month is good enough.
Bring the laser.
Yes.
Because this is calcified.
Well, without implicitly backing it up with trials, that's what you've been stating over the last several years.
Yes. Yep. And no, not only that, not knowing the data of the trial, when Roxanne Maran one day, this is why the trial is still not, the data were not locked. And she said, oh, I'm very nervous about the results. I did say that your work, your tremendous work has to change the guideline, will come positive. I guarantee you there will be no difference in the ischemic endpoint, no difference in the ischemic endpoint, and there will be 3% difference in the bleeding point. And exactly that is what we had. Not knowing the results at all. This we are talking about in June, while they're still looking at the data.
And
so now you see the one balloon had made some difference. Yeah.
Almost all the benefits come from the thin struts, no?
Yeah, thin strut, yes, exactly. And then, and here, any stent was used. There was no difference in stent use. All types of stents were used, Zion, Synergy, Promus, any FDA approved stent.
Right, but amongst them, they all share the characteristic of very thin struts.
Yeah, thin, no, absolutely. There's no question.
Thin
strut has its own advantage.
And the right drug.
Yeah, right drug. And same, like in the stop depth, all were everlumus. And actually in the smart choice, there were all kinds of stents were used. So I think it's becoming more and more generic, and some of the short depth trial using whether Onyx or Evolve, Synergy, I'll show the data. So it seems to be, you get 2020 now? Yeah.
May not go to.
Yeah, there seems to be that any types of current stents will do okay. I mean, not the old one like Biolimus, the bigger, thicker strut, because that's what actually criticized in the Noble trial also, that some of the cases in the beginning were thick struts. So thin strut stent, as you say, 80 micron, are the way to go, better healing, and they give you great results.
Right.
Still not going very easy though.
Well,
You need
all the technical challenges which we thought there would be.
Yeah. Yes. Long
and precisely the purpose of showing the CTO here, addressing issues of antegrade.
Because of the length and so calcium and the blunt tip, so I made that as a J-CTO score 4, although today with the angiogram it looks like maybe 3-0, J-CTO 3, but clearly this was a diffuse disease. Yeah.
2-0?
Yeah, 2020.
So, I mean, how do you compare Guidezilla with the guideline?
And that to that balloon.
Both. Yeah, yeah.
What balloon have they
Yeah,
given us?
2020. Yeah.
It's not going to make a turn.
No, compliant, right?
No.
Yeah, go. Yeah.
No, but not this one.
Which one? 2020.
Yeah,
no, this is good. Yeah. Now, so I think we found both of them. Actually, now Guidezilla with the little better pushability and hydrophilic coating, as long as you are careful that it may cause, if you don't do it over the balloon, may create a trouble. So otherwise it has been working out very good. We were very skeptical in the beginning, but yeah, in the live case, one case we even have a dissection. Yeah, good. Let me go. See, how do you like that? See? Hello.
Let's make sure we are in the...
No, that you tell me, but I tell you the balloon will go. That's all I'm saying. Where it is, I don't know, but it will go. The 2020 has a very good pushability.
Not this company.
Yeah, right there. You have it. Good. Now look for a 2.530.
You have to see a distal vessel.
Yeah. And then get a run through ready. We'll side by side we may advance.
To our viewers, a quick update. Should you have any questions, I'm able to access them if you ask them on the website.
And one of the great credit goes about this Twilight, that all the trial was done by, all these multiple center, multiple countries, all Roxana Maran made it, that all done by ICANN School of Medicine. That was the sponsoring agency, that was the conducting agency, and so superb. Good. What do you want now? Okay, now this is the 2020 we are done. We just need to make sure that it's in the true lumen so far. This good?
I mean, exactly right. To have a command center which is able to get 99% follow-up in 18 months
Unbelievable.
truly speaks of a lot
So
of
tremendous. Oh, sorry. Okay.
exceptional supervision.
Ah.
Okay, down.
And India did a great job also. India randomized 700 patients.
Right. I
With
noticed
11
about
centers.
11%.
Yeah, EHCC, we randomized about 72.
Okay, let's
So
do
then,
retrograde only. Antegrade, I'm not sure.
No,
Right?
not integrate yet. Yeah. Ready? Sine?
Okay, hold on.
No, guide is out. No, your diagnostic catheter is not in. Sorry. The catheter become very soft. You want a new one? Okay, good, good, okay, good. Okay. No, but why the pressure is oh, this
No, it's on
side
the right
pressure?
side.
Okay,
Because
good.
of the
Ready? Okay.
some branch.
Can't make out much.
Yeah, but at least we are in the lumen.
Right.
We may have to get to a different lumen side by side. That's okay. I think we can remove what? What do you want to remove now? And get a run through wire side by side. That's why I would say run.
It was when you tried to get it, it came out.
Yeah, run through wire side by side.
Maybe feel that, no? Run through, okay. No need.
We don't need that now.
Get us a run through.
Right here.
In the branch there.
Yeah. Yeah, take the balloon out.
Looks like somebody was reading the laser.
Yes, yeah, we were.
No, we wanted to. If the balloon didn't go, I wanted to go in with a laser.
You could not have done the rotational atherectomy. And so we warmed up. So those are the cases. So every month we'll do maybe 2 or 3 excimer laser cases, and majority of them are not for stent restenosis or so. They're all just basically for the purpose of this exactly what we have. That if your wire went and nothing else crosses.
So I was doing those 2 or 3 every morning in 1990.
That's it. Laser had its good days.
Well, just took a long time for it to find its true niche.
Yeah.
More in
But
the
still,
periphery.
now we have the data from the NCDR. They say atherectomy is done 5.2%, and laser makes less than 2% of that. Others are half and half, both rota and orbital. And see a little away, curled up.
Yeah, this is what happens when side by side with the.
Now get a new one, new run through wire. So remember that it always has to be careful.
So it doesn't track into a false.
Yeah.
When you're entering the guideliner, you got to watch that it is entering not with the loop. That's what I'm watching at the descending. Give me the needle. Needle. None of these fellows have realized how to curve the.
Yeah, run through requires separate needle, which comes with it. Yep, good. Huh?
We were in the lumen of the PDA.
That's okay.
I think next time. Good.
Yeah, this is the one.
This is the lumen PDA. I think the vessels are so small.
Good. That's okay. That's the way it will be. Yeah. Good.
Okay, I'm going to take this other wire out.
Other wire out. Good. And now we are going to inject, pull back the Guardia in the guide catheter.
It doesn't matter, you have to stand the whole thing.
No, I know. But take antegrade picture.
I think you can. Slow injection. Okay, ready? You will not see much. Okay.
Good. It's a low pressure, yeah. We'll do a slow injection.
Okay, good. That's the vessel we
Yeah,
saw.
it was always the disease. Yeah, 2.530.
And then give us some stents.
Yeah, they're dilating 2.530. We are in the lumen, and let's just complete our slide presentation, please. But we got a lumen, big PDA. I mean, disease PDA anyway. So next
but we
point.
will not going to stent the PDA.
Yeah,
I'm
we
going to
don't.
start
Before
at the
that,
crux
yes.
and come back.
So what I had done is, there are various trials were presented. So we'll just discuss about 3 trials which were related to DAPT. Evolve Short DAPT, Onyx 1, and Model U SES. So these are the same way that how should be the duration and so. So Evolve Short DAPT was a single arm study of 3 months DAPT in patients at high bleeding risk treated with bioabsorbable polymer based everolimus eluting stent, that is our Synergy.
Good.
And basically what they did is they gave DAPT for 3 months and then stopped it and followed for another 12 months. So 15-month follow-up were presented with their primary endpoint was basically in these patients with a high bleeding risk with the death MI, arc definition of stent thrombosis, and secondary endpoint were the bleeding and so. So basically inclusion exclusion criteria, these were the high bleeding risk patient, old age, who had been major bleeding in the past, the patient who have on anticoagulation, renal insufficiency, hematological disorder with low platelet count and so. And these patients were then basically what they did is that patient who after 3 months were eligible for P2Y12 inhibitor discontinuation, and those patients were followed up for 15 months. So there they left it that you could stop either aspirin or clopidogrel. Now those who were not eligible for discontinuation were those made 425 patients, and there the DAPT was continued for 15 months. So basically these are the patient population analysis, the individual lesion characteristics, and the data basically showed that by having this, that overall event rate and the stent thrombosis, look at this, 0.3% at 3 to 15 months with a bleeding of about 7, but bleeding 2 and 5, which we are worried about, is usually 4.5%. So basically that's what it is. So therefore it met the primary endpoint of 5.6, and it was 12 months DAPT as has a 5.7. So clearly from co-primary endpoint of death and MI was identical. And then of course the bleeding, you can see in the 3 months DAPT, overall the bleeding difference is shown here, no significant difference. So conclusion basically was that a high bleeding risk patient, you can use the Synergy and you can stop it after 3 months. Then second trial was Onyx 1, which was a randomized trial of a durable polymer drug-eluting stent, which is Onyx, versus a polymer-free drug-coated stent in patients with high risk of bleeding treated with 1 month of DAPT. So this basically was the trial of BioFreedom, which is A9 drug-coated stent. There is no polymer on that compared to the durable polymer of the Resolute Onyx. And these are the stent designs, and basically showed that about 2,000 patients of Resolute Onyx versus BioFreedom showed these are the criteria they call high bleeding risk, elderly age, kind of same way. One OAC patient is taking, patient has renal failure, anemia, thrombocytopenia, and so on and so forth. And basically what they found that after 1 month that the aspirin was discontinued, and that is the key. So patient was in the aspirin group, in the Resolute group, aspirin was withdrawn after 1 month. in the biofreedom continued for 1 year, and basically what they found is 16.9% in the biofreedom with a safety endpoint and 17% in the resolute. So basically identical. So 1 month of depth with the resolute did equally good as shown here, and the individual endpoint of the death MI stent thrombosis, and all shown here. No difference at all. So then question comes from 1 month to 15 months. What was the difference? Again, there was no difference, and that lead to total effectiveness, target lesion failure, cardiac death, MI, TLR, all were identical between two, and so also the bleeding. Although we felt that maybe bleeding should have been a little lower in the resolute, but did not, but identical. So summary basically was that is a contemporary trial of 1 month of DAPT in a patient with a high bleeding risk is completely safe, and that is the key. The third trial was the 3 month discontinuation of DAPT after bioresorbable polymer sirolimus eluting stent called Model U SES, done in Japan. Basically what they did is the patients who were appropriate, they randomized discontinue aspirin or P2Y12 at 3 months, and they compare the data with the historical match from the century 2 where long DAPT of 12 months was given. So it's a single arm trial with a historical control comparison, as you can see here, of 1686 patients. Half of them they stop aspirin, other half they stop P2Y12 inhibitor, and majority of them was clopidogrel. And basically these are the individual and the clinical characteristics, and what it showed: 4.4 incidents of death, MI, stroke, stent thrombosis, and significant bleeding at 1 year. So if you compare model US SES with the century, clearly it seems to be that it is in favor of discontinuing the DAPT whichever way we want, whether aspirin or a P2Y12. So you can see here that at 90 days, and after 90 days landmark analysis shown here, and these are the individual endpoint of the death MI, and of course BARC definition in these patients. So now second issue was that these are the individual endpoints shown here. The second was, what about aspirin versus P2Y12? Was there a difference? No. Whether you discontinue aspirin or P2Y12, the outcome were identical as shown here. So basically they also showed that after 3 month DAPT, you can stop one of them without having any problem. And this was not in the patients of the bleeding, but any patients group and so. So take home message of Twilight and the DAPT trials was, Twilight trial is a landmark study showing that even in the high clinical and angiographic risk cases, you can stop the aspirin after 3 months without harming, rather having a lower bleeding. And of course, it was true both ACS and stable CAD patient. And this is continuation of, I showed you the global leaders, the smart choice, the stop DAPT, and so that aspirin is no longer necessary. Second, in patient with high bleeding risk, a strategy of single antiplatelet therapy of P2Y12 or aspirin is safe after 1 to 3 months. And of course, numerous trials have shown that DAPT abbreviation to 1 to 3 months post current DES is safe, and there is no increase in ischemic endpoints or stent thrombosis. Therefore, guideline need to incorporate that, because we do get trouble with the anesthesia and other team because they know nothing in the guideline that some cases you can abbreviate the DAPT duration. So with that note, I'll just finish my questions here. The Twilight trial evaluated ticagrelor therapy in all following clinical scenario except diabetes, stable complex CAD, unstable complex CAD, STEMI, and bifurcation CAD. Clearly, it was not a trial of the STEMI. Then second, following are the correct conclusion of the Twilight trial except aspirin discontinuation after 3 months resulted in lower bleeding. Aspirin discontinuation after 3 months was associated with similar ischemic endpoint. Aspirin discontinuation after 3 months showed trend towards higher stent thrombosis. Ticagrelor alone was effective in both stable and ACS CAD, and ticagrelor alone was effective irrespective of the lesion morphology. Answer there is yes. There was no difference in stent thrombosis. And the last question is, following are the trials evaluating DAPT duration except Evolve Short DAPT trial, Augustus trial, Model U SES trial, Onyx 1 trial, and Smart Choice trial. So clearly we know that which of the trial, the depth interruption duration was all of them except Augustus. Augustus was the trial of apixaban, and that was randomized to aspirin versus no aspirin. and so that will
I
be
mean,
the correct answer
excellent
for this.
review, beautiful questions. I mean, they summarize the entire topic. Anu, follow up from you.
He is going to give us some positive update now.
Yeah, the patient
Nothing,
could
you guys
also
have
do
done
with
a
a
nice,
little nitro.
discussion of antiplatelet agents. We finished the CTO by ourselves.
Yeah.
Yes.
No,
well,
we have been with you.
Yeah,
It's
please.
not alone. We have been. So what we have
Anu,
done so far?
today's case, I think you deserve special praise for a reason that the delay in the case did not affect your demeanor. That is something many people should learn from. Things don't necessarily go exactly the way with our schedules. It can unruffle a mind, and you kept excellent calm. I'm very familiar of how your busy is on a Tuesday, and I know what it has done.
It's a short. I think you need to bring back bigger, longer, no?
Okay, some die.
Okay. Okay. Oh, good.
Looks excellent.
Pull back 2 millimeter. Yeah, definitely. Good.
What size is this?
These are 275 now.
Wonderful.
And earlier you put a 2.5? 38. Which one is what is 10?
Zines.
Okay.
Die. Good. Okay. Pull back more a little bit.
Yeah, you can pull back 1 or 2 millimeter more.
See, when you're doing osteal stenting, I think this is not a good guide. Some die again.
Good.
Okay, go up now.
Going. So
Years and years watching you, Anu, I'm just amazed at your steadiness and just excellent skills. So much for the audience to learn.
You want to go a little overlap? Why you pull back? Why that back?
Okay.
And to our audience, once again, our apologies for the glitches which happened early in the program, but the caliber of the case and the discussions with Dr. Sharma and Dr. Kinney hopefully have made up, and Dr. Mehran.
Go. Awesome.
You can go higher.
12, 14.
24.
4 mans.
I
was surprised that was really pulled back.
Yeah. So this just, what we do is in the ostium, we will go out rather than using osteal flash. We brought a stent up to there. So that gave you 24 atmosphere and try to avoid putting any additional balloon if necessary or so. And that way you have made, and we are ready to take the picture and turn, see.
Too small?
Keep it the same, yeah.
Go.
All right.
Wonderful job. Anything needs to be done for the very distal PDA or leave it like that?
I think no, we actually stented into PDA. We still have the AV continuation. You can see from the dual injection, it was like a diffusely diseased vessel.
Yeah.
Probably likely grow by itself. Yeah.
And
excellent job. Anu, final comments from you, and we let you and the audience leave.
Yes.
Yeah. No, I think here we did change of the wire. You saw fielder instead. I think Gaia it is excellent wire, but you have to be very careful. It does go subintimal. That's what happened, went subintimal. So when we went with the newer guide, just went with the confidence at 12 right from the proximal part of the RCA. That took us into the lumen. And it was diffusely diseased, but the question was the same and calcified. So the balloon, which was the 1.0 balloon or 1.25 did not go, 1.0 balloon, which was the sapphire balloon, actually went through the whole lesion. We were able to dilate it. If not, we were ready with the laser. Laser was warmed up because that was the third. We tried by 1.25, which was a splinter legend, did not work. 1.0 worked, and then once the 1.0 did the trick, then we went with a larger balloon, dilated, and just did a stent. Yes.
Anu, superb skills, excellent teaching points. We finish our case here today. Sorry for the delays. See you during the next transmission on November the 19th.
All right, very good.